session at 1:00. So we have
A few minutes. If anybody needs a bathroom, urology break, it's around the corner, of course. Refill your water or your coffee, whatever. And we're going to finish the summit. And I hope that you're going to be really happy with the next session too.
So Mark, I see one.
Okay, 2 minutes, everybody.
You can say what's more exciting in the clinical trial in early bladder. This will
Yeah,
then.
and that's, well, Jen's gonna talk about that, and then I'm just wondering where you want to, when you want to show this thing.
I'm saying it would make more sense if you let Jen lead.
Yes.
Because if you answer the question to Jen that.
About
what-
trials.
About trials in early bladder, then it will be reflecting of our slide.
Mhm.
And then once our portion is done, then you
Yeah.
say, okay, Parminder, what's going on in the
Okay,
event?
fine. So you can skip, because the order's a little different, just skip through the blue light slide and then go to
Unless-
Parminder's slide.
No, you
Right.
asked about early bladder, then like. Then,
We've sort of
yeah,
got the order here.
it's same order before.
It'll-
Yeah.
Well, we're just gonna.
Yeah.
It's supposed to be a very. Yes.
All right, everyone, if you could get your seats again. We did save the best for last. I'm going to turn it over to Diane Quale, Beacon's co-founder, who's got it from this point forward, okay?
Test my mic. Okay, can you hear me now? No, can't. Oh, now you can. I can hear me. So now you can hear me. Well, it is my great honor to welcome our 3 guests here today. And I want to thank you all for joining us. It's just, it's such an important part of the summit. And to have you here really means everything. So thank you so much. I'm just going to dive right into this because I know we're all anxious to hear from our experts. And first, I would like to introduce them. Directly to my left is Dr. Donald Lamm, who's a urologist with more than 47 years of experience treating genitourinary cancers, especially bladder cancer. Although he's recently retired, Dr. Lamm is still engaged in research. And for those of you who've had BCG treatments, this is the man. He's been a pioneer in the field of immunotherapy since the early 1980s, having done the trials for BCG and getting BCG approval. He's established the well-known Lamm protocol for the induction and maintenance of BCG, and it's wonderful to have you here, Don. Next to Dr. Lamm, we have Dr. Parminder Singh, who I think many of you in the audience already know. He's a GU medical oncologist at Mayo Clinic, Arizona. He's a national leader for multiple registration trials evaluating new strategies to preserve bladders in bladder cancer patients, something we all are very interested in. Welcome, Dr. Singh. And you've already met Dr. Jennifer Linehan, who we know is now an Arizona resident, an Arizona native, although now a resident of California. She's a board-certified urologist and is Associate Professor of Urology and Urologic Oncology at the St. John's Cancer Institute in Santa Monica, California. Welcome. So I thought I would start just by asking each of you, and I'll start with you, Dr. Lamm. I can say from my experience, having been in the bladder cancer field now for 23 years, that especially in the last 10 years, and certainly in the last 6 to 10 years, there have been a tremendous number of changes. And we talked earlier this morning about hope and everybody having a reason for hope because of the advances. But given that we have a limited amount of time today, can you tell me, and I'm going to ask each of you, what do you see as one of the most exciting advances in bladder cancer or bladder cancer treatment over the past 5 years? And one.
Oh, that's the hard part, the
Yes,
one
the
part,
one.
because there really are so many things. And part of the upside of the BCG shortage is there's now an opportunity to study many new drugs in bladder cancer that we didn't have before. So, but I have to say that in my opinion, and I hate, you're probably going to want to say this one too, but I got it first. The big step forward is in what immunotherapy, of course, and it's a combination of the immune checkpoint blockers, the pembrolizumab and the durvalumab and the other drugs. And often, and I think generally very significantly improving the response is combination with other agents, primarily BCG, but many other agents. So.
Great, thank you. Dr. Linehan, your turn.
So one of the things that I think, well, two, there's, okay, I only get one. So I'm a technology person. So I think there's better technology at finding bladder cancers. I think there's better urine tests at finding bladder cancers. And I think robotics to take out the bladder that has also improved. And then, of course, some of the trials that we talked about too.
Great. And Dr. Singh.
First of all, I would like to thank all my patients who came over. We sent a flyer and I see folks from Colorado. Laura is here from Colorado. We have Prescott here. We have Kesters from Tucson and Cheryl and John and Jack and so many folks from local Arizona taking our time today on a Saturday. You could have gone to the Tempe Arts Festival, but you decided to come here. Thank you so much for doing that. But I think personally, in last 10 years, the biggest advancement in bladder in the US is actually BCAN. It is not pointed out so much the role of advocacy in bladder cancer research, which Diane and her group has led. And I'll allude to the development of the largest clinical trial in bladder preservation, which I said Rick Bangs, my partner, patient advocate who took charge and helped me push through NCI because nobody was ready to fund that trial. And this is all because of the advocacy, which in the last 10 years have changed the way bladder cancer is funded and the field is moving. I think this is the biggest change in bladder cancer in the last 10 years.
Thank you.
Sure, yeah.
Thank you. So recognizing that bladder cancer really represents a whole spectrum of diseases from non-muscle invasive to muscle invasive to advanced, we're going to kind of do our discussion through those phases just to keep it simple. But the first question I have really has nothing to do with research advances. It might be why there hasn't been an advance. Dr. Lamm, I'll start with you, and then Dr. Linehan. Why isn't there a screening test for bladder cancer? We have PSA for prostate, we have mammograms for breast, we have colonoscopies. Why isn't there a screening test for bladder cancer?
Well, We do have screening tests, but they're not terribly good, and there is progress. There is accelerated approval of a new urinary marker system, multiple markers from simple urine tests, and that's being developed, and I think you'll see it before long. We don't. One of the big needs is just something that will tell us if all the cancer is gone, in which case, you don't need more chemotherapy, and that would have to be a blood test because, when the cancer is actually in contact with the urine, you'd expect to find something in the urine that would tip you off. But the real problem is not having a PSA type test, and there's a lot of research being done, the genetics and the cellular markers that DNA that can identify minute amounts of cancer, but it hasn't really come to fruition in bladder cancer yet.
So there's nothing that's widely accepted and available so that when I go in for my annual checkup, that there would be a screening.
Well, but you need to acknowledge, we need to acknowledge the importance of what you're doing, and that is letting people know that if you have frequency without an infection, or if you have microscopic or certainly visible blood in the urine, you need to see your doctor, and typically you need to see a urologist. And, just the good old-fashioned cytology is very good for diagnosing the dangerous, the high-grade type of tumors, not so good for the low-grade at all.
Dr. Linehan, anything to add? Sure. So I think you have to think about it as a comparison. Let's just take prostate cancer and pancreatic cancer. So the pancreas and the prostate release this enzyme into the bloodstream that you can measure in the bloodstream. And there's nothing really like that that's emanated from the bladder. The bladder's not making any enzymes or things that you can actually check. But okay, so we have urine. It's an easy and free test that you can get. Everybody's got to pee. So the problem is what's important in the cells and on the cells that we need to be measuring. Is it the DNA? Is it the mutations of the genes? Is it the receptors on the cell and the markers and the things that the cell may be pushing out to show itself? So we're trying to understand which of all those markers is important to pick up cancers in the urine. And that's why the tests have been so difficult to formulate. There's 8 different urine tests on the market right now, looking at all different things. Like you have the cytology that Dr. Lamm was talking about, where the pathologist puts it under the microscope and says, is there a cancer cell there? But then there's tests that look for DNA markers and mutation markers. Then there's tests that look for things that are on the cell that are like called keratin. So there's all these different things, and we're all trying to figure out which one is most important and what's going to give us the best result. Because if you're going to do these tests, you want to make sure the test is actually very specific for bladder cancer and sensitive to bladder cancer, or you're going to have a lot of false positives, and that's going to create, a lot of anxiety for patients, right?
And so talking about biomarker tests, is it different for screening, trying initially diagnosing a patient with bladder cancer, than having a patient who's been treated for the disease and now they are under surveillance? Are there biomarkers that are more precise in that instance?
Yeah, absolutely. And one of the reasons that they are more precise is because we have tests that now you could take the patient's cancer and check for their mutations, check for the things that are part of the cellular makeup of their cancer, and then kind of screen for those things, even personally on them. And we understand that certain mutations show up in more aggressive cancers than in low-grade cancers. And so the tests become more specific, which makes them better at finding. So if you know someone has cancer, you sort of know what you're looking for. Whereas if you're just randomly screening the population, it's harder to pinpoint.
So what are some of those tests for patients who are under surveillance for recurrence?
So we use, there's CX Bladder, there's Oncuria, there's NMP22, there's Eurovision, and then there's the cytology. And a lot of us as urologists, depending on the type of cancer, whether the patient has low grade or high grade, I will use some combination of those tests. I probably use, CX Bladder in my practice the most. But like I said, I tend to vary it up and change depending on what type of cancer it is. But those tests in themselves are individually based on what type of whether you're trying to screen, whether you're trying to survey, meaning you're following a patient with bladder cancer, or trying to detect if a patient has bladder cancer. And the company changes the assay for all of those different classifications because they're looking for different markers.
And do any of those markers hold the promise of reducing the number of cystoscopies that patients need?
Yes,
As part of the follow-up?
absolutely. I think, as we continue to gather research on these urine tests, we will understand if you test positive with this test, that, we know that something may be there. And if you test negative, well, maybe you don't need your cystoscopy. And I think as far as screening using the tests for patients that come into your office with microscopic hematuria, if that test is negative, we may know that, okay, you really don't need a cystoscopy. The urine test was negative. Like I said, urine is a very easy specimen to get from patients. So.
Diane, can I ask?
Yes, please.
So, Dr. Linehan, how is the coverage of these tests? Where insurance pays for this, or patients have to pay for this test?
So now most of the tests are covered. If insurance doesn't cover them, most of the companies will help the patients either get the test covered through their insurance, or they'll just cover the cost of the test for the patients. But to be honest, I can't remember in a while the last time that a patient said, hey, I got a bill for this test.
So you would be doing these tests every 3 months, 6 months, every year, or just once?
No. So, I'm repeating these tests when they're coming in, every 3 months or every 6 months, depending on where they are in their course.
And are you doing these tests in lieu of cystoscopy or in addition to?
I am doing the tests for screening, sometimes in lieu of cystoscopy. In patients that I know have like high grade bladder cancer, I'm not yet comfortable just doing the tests.
Okay. So, talking about cystoscopy, so one of the great advances, I think, in my time in the bladder cancer field, is blue light cystoscopy. So, and I know we have a slide if you want to share. And can you talk to us about blue light and the advances there?
Yeah, so the benefit of this type of cystoscopy called blue light is that you can find lesions that are very, very small that you would not see with your naked eye or white light cystoscopy, probably what the urologist has been doing in the office. So this uses a dye of what we call a photosensitizer, and you put it in the bladder for an hour before your cystoscopy. And you can either do this in the office, or you can do this in the operating room, like before you're going to take a patient back that has a tumor inside the bladder. And if the actual scope itself is what the blue light is. And when you click the blue light on, tiny little lesions will show up bright pink like this. So, and you can see the picture right next door. I would have never seen that lesion with the white light. Like, it would have been a very soft call for me. I would have had to look really close, or maybe I would have had to spend extra time looking, but you can see these small lesions, which means that you can get them earlier, which means maybe not as many cystoscopies and definitely avoiding the operating room more. So it's been an incredible technology to have. And so if you can see, just I have some numbers up there that, it improves the detection of these smaller lesions, 95% versus 68% with just looking with your eyeball. And this was just some more other pictures of what that looks like. So I know it's called blue light because it's very confusing to patients. So the blue light's in the scope. but the lesions actually come up pink.
Has anybody here, how many people here have had a blue light cystoscopy? Great. Has anybody wanted one and not been able to get it? Okay, there's the other problem. Okay. Okay, well, hopefully, and you can, isn't there now a flexible blue light so you can do it in the office? It doesn't require going into the operating room?
We do it in the office and then we do it in the operating room.
Right.
So if I have a patient with a bigger tumor who I know I'm gonna take to the operating room anyways, then I use it so I can see all the little stuff. And then I have some patients with low-grade bladder cancer and those tend to recur quite often. And then you can see it in the office with the flexible.
There is something between regular white light and blue light, and that's the narrowband imaging. And which is what I use because we didn't have blue light, and it is, significantly expensive. But you just push it once you have it, and it doesn't cost that much more than a regular scope, and it's flexible. You just push the button and you flip from white light to narrowband imaging. And it compared to just white light, you do see more, and you can do it a better cystoscopy, not perfect, but
But you can also do that in the office setting.
yeah, in the office, and it's click and it doesn't cost anymore.
And most urologists have
The
that,
narrowband.
the narrow
Yes.
band that he's already talking about,
Mhm.
which is another.
Right, right.
version.
And is the blue light being covered by all insurance companies?
Yes.
Right. And I should have mentioned at the outset, we're going to have our conversation up here, and then we're going to have at least a half hour for your questions. So if things come up as we're talking, just write them down so you can remember, so you can ask questions at the end. Well,
So from patient's
Yeah.
point of view, does blue light cause any more radiation risk, or is it just a light color blue?
Oh, it's just a color blue and
Mhm.
we have like a fluorescent light and just fluoresces, but it's very safe. It's not harmful. It's not really a dye, even though it sounds like it would be. And patients have usually zero issues with it.
No dye-related kidney issues or those?
No,
kinds of-
yeah. Because it's gonna go in your bladder and then we're gonna drain it right out.
Yeah.
Great. Well, let's turn to BCG.
All right.
Let's turn to BCG. It was, we're all excited about the new immunotherapies for bladder cancer, but it is an immunotherapy that's been around for quite some time. And we have you to thank for it. Don, tell us a little bit about any concerns you have with the ongoing shortage of BCG and how you think that might be impacting patient care.
Well, I haven't looked up the numbers, but we know that patients are having compromised care because of the unavailability of BCG. And I think there are more bladders that are being removed that might well have been saved if there were sufficient BCG to go around so everybody could have the optimal treatment. There should be BCG for everybody to get 6. It took forever for us to prove that maintenance was better than just induction. They looked at monthly maintenance, they looked at quarterly maintenance, and it was not until we started the intensive 3-week, 3-year maintenance program that we're able to really show a big, big difference in prevention of recurrence. And it's the study that the schedule that has been shown not only to almost double the benefit of BCG, but to significantly reduce metastasis and mortality from bladder cancer. And we need more BCG because the guidelines, which are the guidelines for BCG in the shortage, say that kind of use BCG as a last resort for intermediate risk bladder cancer. but the European study 30911 looked at intermediate and high-risk patients, comparing the 3-week maintenance BCG with 3-week maintenance epirubicin. And
Epirubicin is a chemotherapy.
is a
drug,
chemotherapy,
right?
yes, it's, you know, a kind of like a doxorubicin type of drug. It's a good drug. But the patients, and there were over 900 patients in the study, 500 of whom had intermediate risk. They excluded carcinoma in situ because everybody accepted that BCG is best for carcinoma in situ. It's ideal. It's superficial. The medicine comes right in contact with the cancer. But they found that the group that had the greatest protection was actually not what we expected. It was the intermediate risk group. So intermediate, even low-grade tumors that continue to come back tend to get worse and are dangerous. So we definitely need more BCG. I'm working with 3 different companies trying to develop a way to get more BCG. I mean, there will be a new manufacturing site in Durham that Merck hopes to have online in 2026. But still, it's a long time, and there's a lot of patients that are gonna miss optimal care until that time. So we're trying to get, and there is promise with Dr. Robert Svatek's SWOG study looking at Tokyo 172 BCG.
Which is a different strain of BCG
Yeah,
than what's
yeah.
approved here.
It all came from Pasteur in July of 1921. But, and this is makes me feel so good to be a BCG advocate. Doctors Calmet and Guerin developed this. It took them over 10 years to develop it. They developed it, and, you know, it saved the life of a newborn whose mother died and was going to be raised by the grandmother who had active tuberculosis, and the chances of that child making it were slim. So they said, well, it's time to do it. They gave him oral BCG and, you know, lived happily ever after. But that was such a horrendous disease, tuberculosis at that time, that they, without patenting, without anything, they sent it to countries all over the globe for free. And unfortunately, it took a while for us to figure out that you needed to have a seed lot and preserve the original. So with serial passages around the world, there are some differences in the strains of BCG, but I have not seen one yet that is not effective in bladder cancer, looking at carcinoma in situ response rate. So,
Well, so you had mentioned at the beginning that one of the upsides of the BCG shortage is all the trials that are going on now, because there's an obvious need for alternatives to BCG. So Dr. Linehan, I know you have this wonderful visual for us. Can you talk to us about what's going on in the non-muscle invasive space?
Absolutely. So first of all, I am very honored to be sitting on stage with Dr. Lamm. There's no one in this world, I'm pretty sure in this world, that knows more about BCG or intravesical therapy. So he definitely is the father of that. So if I say anything wrong, just tell them right away. But this is a slide, and there's no way we could go through all these trials, but the point I wanted to make, this is a slide by another really great urologist named Max Cates, and he presented this at ASCO. And it's showing you the different types of cancer, and then what trials are available and when those trials started. Now, you don't have to worry about reading this because on the Beacon website, there is a clinical trial finder. And you can put in your cancer and it will show you all these different studies. It'll show you what they're doing and it'll show you what you have to do to be included in those studies. But my point of this is because of the BCG shortage, a lot of this came to be. A lot of this came to be because of Beacon, because they worked very hard at getting these trials pushed through. So there are, if you've had BCG, there's cancer that, patients that have cancer that have not had BCG yet. So those are BCG naive, meaning they never had it. So those trials, those patients can have those trials. There are patients that are what we call unresponsive, meaning they've had 6 weeks of BCG and probably another one after that, but the cancer keeps coming back at some point in time, either right away, it never left, or it comes back. And those are the trials that are candidates for, right there, the BCG unresponsive, and then at the top, it's intermediate risk. And there are actually now is a urine test called oncuria that you can get that will tell you if the patient will respond to BCG. So we are getting better about figuring that out as well.
Really important, really important. I know that one of the trials that actually Max is doing, but there's also been work done on this in terms of alternative therapies is chemotherapy and using the combination of the docetaxel and gemcitabine?
Yeah.
Gemdosi.
Gemdosi, yes, I never get that right. Gemdosi. How does that compare to BCG and is it, do we know who it might work better for than others?
Do you want to take it first?
Okay. Yeah, this is a very, very effective combination. And as an example, we had a patient who had a huge tumor, two very difficult large resections at Memorial Sloan Kettering. He absolutely refused to have his bladder out. He came to see me, 2 huge resections, and he was, you know, and initially it was so big you couldn't get it all out in one setting. But even when you could get it out, it was growing so fast that, you know, you couldn't keep up with it. And we had BCG at the time, but it takes 3 months, sometimes even 6 months, for BCG to stimulate the effective immune response. It's going to get rid of the tumor. So we gave him gemcitabine docetaxel, and he did just fine. And then we, knowing that he was going to remain at risk for recurrence, we gave him BCG, and that's been like 10 years ago, and he's still fine. So very rapidly recurring tumors, gemcitabine docetaxel has an advantage over BCG. I think in the long run, had we been able to do, you know, 3-week maintenance BCG and so on and so forth, I think BCG is better than the combination. The reason being that it stimulates an immune response that persists, not forever. I don't know that, but we don't think it lasts forever. But it is long lasting. So when you develop a new tumor, your immune system can recognize it and eradicate the tumor. Chemotherapies are actually carcinogenic, and I shouldn't have said that, but there was so much disparagement of BCG when it first started, and you know, I got to get back a little bit. But it doesn't, it's great for killing tumor, but oftentimes the DNA that produces the mutations that produce the tumor in the first place will eventually break through and cause new tumors. So I prefer BCG as an ideal option, but the numbers are very comparable.
And so the gemdosi goes into the bladder. It's not, it's an intravesical therapy, right? And when you do that, what's the, how often do you get installations?
So if we're gonna do a chemotherapy into the bladder with the gemdosi, which Dr. Lamm is right, it is, I just looked at the data recently again, it is very comparable to the response rate, the cancer going away that you get with BCG. It's not as good, but it's pretty darn close. And so in that setting, you have to give, there's two drugs, right? So you got to give the docetaxel first and then the gemcitabine. They each have to stay in the bladder for an hour. And so the patients are spending a little bit more time in clinic, but they're doing that once a week for 6 weeks. So, is there another?
No,
Yeah.
no, that was, for people for whom BCG does not work and they are not ready to have their bladders removed, is there a good, before we get into bladder preservation, is there a good other treatment for them to try?
As many as 80% was responded gemdosi, yeah.
Oh, so the people who are non-responsive to the BCG gemdosi will work.
Yeah,
To 80%.
well, you know.
Right,
Can
exactly.
work,
It
can.
can work, yes, yes.
So I think what we're still trying to, so if you think about the different types of non-muscle invasive bladder cancer, because remember, once it gets into the muscle, that's changing the treatments that we need to do, and you need to see this guy over here. But if it's non-muscle invasive, we can put the treatments into the bladder. That's intravesical therapy. There's many ways to do that. You have the immunotherapy, which is BCG, and BCG plus other immuno agents like Pembro or Opdivo, or those kind of drugs. We were talking about that earlier. And then you have the chemo section. So there's multiple variations of chemotherapies and combinations of chemotherapies and heating chemotherapies like Dr. Lamm taught us to do, you can put in the bladder. And then there's what we call target therapies. That's where we test your cancer and it says that it has this mutation and we have a drug that targets that mutation. And then you can put those drugs into the bladder. So there's lots of different ways to go depending on what might be best for the patients. And a lot of these things that we're learning are still in clinical trial because we don't know, okay, we might know they work as well as the BCG, but do you have to give the patients maintenance or how long is that going to work for? Those kind of things we're all still figuring out.
And now nadofaragin is also approved for BCAN response. Yeah. Do you want to talk about that new medication, nadofaragin?
The nitrogen,
yeah.
yeah, so there are patients that have, there's another intravesical chemotherapy that is approved. And again, that's based on if you have a certain mutation in your cancer. So if you have that mutation, then that would be the best drug for you. And that's the FGFR mutation. So.
Yeah, so, and, you know, there are two drugs which I think should be available this year. One is FDA is reviewing their data, which is again an immune therapy, interleukin-based immunotherapy. And one is going through is already approved, but having some production challenges. Should be available by middle or end of the year. Is nadofaragin is based on a virus vector, which can help induce your immune response to kill the cancer. And so I think the options for bladder cancer in non-muscle invasive setting is now the portfolio has, is expanded dramatically. And there is hope for a lot of patients now beyond BCG and traditional chemotherapy like gemdosi. Yeah.
Well, so let's move on now to muscle invasive disease. And I know, Dr. Singh, that you also had a slide for us on some of the trials that are available in that space.
Sure, yeah. So, I think from the medicine point of view, certainly the field has changed in last 5-6 years with so many options, as we talked about immunotherapy. And many of the patients here in the room had exposure to immunotherapy in my clinic. And also newer drugs, which are more like delivery system. These are, think of it as smart bombs. So there are antibodies which are looking for special targets on the cancer cell. And behind on their tail, we have attached chemotherapy molecule. And this delivery system or this antibody looks for a cancer cell in your body, wherever it is. It will go and attach to the cancer cell and inject the chemotherapy into the cancer cell and kill the cancer cell. So a very smart delivery system. And they have revolutionized the way advanced disease patients are now responding even far and beyond than what I saw with immunotherapy by itself. And they're kind of changing the whole the treatment paradigm for bladder cancer. Now they're moving up into early stage disease, and we have John here who is on a clinical trial in early stage disease, where we are going to investigate this new antibody chemotherapy molecule. But I would encourage patients to enroll on clinical trials as these help move disease treatment options forward, like all the trials which Dr. Linehan showed regarding bladder cancer in early stage. You should ask your oncologist or urologist to get you access to trials, so then you can get access to new drugs. One, and it also helps move the field forward. And so just to point out here on the screen, you see I've just put in the stripes. They reflect when the new treatment came on, and you see here since 2016-17, so many new drugs came up. And above the blue line are the new combinations, which are now very close to finishing of those trials, and maybe they'll get approved. So the field for advanced bladder cancer is kind of exploding in a good way for our patients.
So a question, I think for all of you, because we've talked about targeted therapies and even in the immunotherapy and the different mutations that a particular tumor might harbor. Do you think that genetic testing should be standard of care for all bladder cancer patients?
Yeah, so certainly, I was thinking about, I knew this question is going to come up in this meeting, and how to address this, because a lot of patients come in and they ask about genetic testing. But the one, it is an expensive test. And second is the applicability in my patients who I am seeing. There is a new drug which is listed here on the list now. Oh yeah, the yellow strip, the erdafitinib, is a drug which targets a special mutation or DNA alteration called FGFR. So some patients whose tumor has FGFR3 alterations, then we can give this drug. But the problem is that there are very few patients who have this. So then I have not seen, even though that test is available and now Medicare pays for that test and we can get it done on each patient, costing close to $3,000. But then in terms of care planning, we are still lacking drugs which would target mutations. And so I have, even though that information is critical to understand how the disease is progressing or to do clinical research, it hasn't boiled down to actual ground level for our patients. None of my patients here in the room have had this mutation, except I think, John, you have this, and we had talked about this. So one patient in the room has it. I think I have like 20 patients here. So very few patients will have this mutation. And so the drug applicability is limited, even though that test is critical to understand the disease. But on the flip side, I had always believed that this cancer is chemosensitive. It responds to chemotherapy. And whenever we throw some chemotherapy, it works. So Dr. Lamm threw gemdosi, it works. We would throw paclitaxel, it will work. And so the moment we figured out there is a better way to deliver the drug, and Daniel, you had enfortumab EV, and stage 4 disease now in remission. I think there are a few more patients who had stage 4 disease, cancer just melt away because we can deliver the chemotherapy to the target, and these cancers, they respond.
Was this personalized therapy? So you knew what you were targeting and you had a specific drug for that target?
So that's the beauty of this. There is no personalization. It has a wider applicability. 85% of the patients who have bladder cancer express that protein, which this antibody is looking for. Okay. So I don't even care about testing. Why would I spend $2,000 to test? It's 85% patients will have this anyway. So we just give the patient the drug. And if the tumor is shrinking, then it's working. If in some patients it doesn't shrink, which we would know in 6 weeks on a CT, we stop the medication. But if it is working for you, I have patients stage 4 disease in the room who are in remission. The beauty, I'm going to tell you a story. When we did the original clinical trials at Mayo Clinic, I had a gentleman who came from hospice. He's like, Doc, I want to try anything. And we had just opened the trial for enfortumab. He had over 25 liver metastases. I was like, okay, I don't even know if the sponsor will approve you as a candidate. But his liver function was normal, so because his otherwise liver was healthy. I gave him enfortumab, 6 weeks, everything gone. He lived for another 2 years and he died of UTI, not from his cancer. So I think there is a lot of promise for bladder cancer coming, and Petros Grivas brought about sacituzumab, which is another similar antibody drug conjugate. And now we are combining them with immunotherapy. So if you see the orange line just above the blue line, the enfortumab and pembrolizumab trial, the FDA is reviewing that, and we may get it approved as a combination where immunotherapy is going to go with this smart chemotherapy, and will then open up 7 out of 10 patients are responding to these combinations. Never seen before the kind of responses I'm seeing with these drugs. Yeah.
That's wonderful.
Yeah.
Very hopeful and promising.
Yeah.
Going back from advanced disease to muscle invasive, because we've also had this conversation while we're here, because it's very important for many people to keep their bladders. So when you have muscle invasive disease, the standard of care has been chemotherapy plus bladder removal. Is that the only option?
So I knew Diane is going to ask me this. So she asked me to put a next slide on to show folks what she's talking about is bladder preservation. What is bladder preservation? And my interest has always been to preserve the bladder. And so when the BCG stopped working, we opened the clinical trial 1605, which was looking at immunotherapy in BCG unresponsive. And unfortunately, it did hit the statistical threshold, but Keytruda's statistical design was such that it hit the benchmark, so it was approved, even though the results were comparable. But then similarly in advanced disease patients, which is more patients who have muscle invasive disease, but are still limited to the bladder, can we preserve the bladder? And believe it or not, in US, this was not considered a good option for bladder cancer, even though across the pond in Europe and UK, people were getting it all the time. Even in Canada, this is very prevalent, but USA folks were not interested in studying this. And that's where patient advocates pushed for this trial. I couldn't find anybody to support this idea in 2016, 17, when we proposed this. But then patient advocates pushed so hard that NCI, FDA, everybody agreed that, okay, we'll let you move with this trial. And this is looking at a combination of chemotherapy, radiation, and immunotherapy to see if we can put all that together and kill the cancer and prevent it from coming back. Now, it is not a good option for everyone. And there are folks in this room who I have told that this is not a good option. And I have folks in the room who I told this is a good option, but they decided not to take this. So John and Jack, we will ask them to comment on why they didn't opt for radiation when we talked about it, because there is something which comes after the treatment, which is the follow-up. Because once you go through this treatment, your bladder is saved, but you have to follow. Every 3 months have a cystoscopy, which could be painful, discomfort. So that's where Dr. Linehan's research comes in. If we can find out the recurrence without doing a cystoscopy, they may have to undergo repeated biopsies. And then in future, if the cancer comes back, then you will have to have your bladder removed at that time. And what if it comes more advanced at that time? So that's the risk that there's always there. So some people don't like that, and they want their cancer to be out of the body, and that's okay. But then at the same time, there are folks who may not be a good candidate. So I have a gentleman here who wanted it, and I said, no, you are not a good candidate because in men, as we grow mature, not older,
Thank you.
our prostate gets bigger. And invariably, many patients will require their prostate to be scraped with age to help alleviate difficulty in urination. And if the radiation is done in that area, then those problems will become aggravated, and your quality of life may go down after preserving your bladder. And so you don't want to actually decrease the quality of life by keeping your bladder in, because if you have to pee every hour post radiation, then it doesn't make sense. Why would we preserve that bladder? So you have to select the patient right. Patient has to be motivated to follow up so that we don't miss the cancer coming back. Bernadette here She can talk about her experience with radiation, and she's doing fine. But you have to be strict with your follow-up, and it can certainly be done. It's an option, which is a great option, and we are trying to improve the outcomes even better with these clinical trials.
One other kind of bladder preservation that I'm aware of is, and I know they're doing this, been doing this at Sloan Kettering, so I'd like your thoughts about this too, that the patients undergo the chemotherapy and then they are scoped again. And if the bladders look clear, meaning the neoadjuvant chemotherapy works, then there's watchful waiting. Can you speak as to your thoughts about that, and is it really a viable option? Is it a safe way to go?
Yeah, there are some patients who will have a complete response to combination chemotherapy with muscle invasive disease. But we don't just look, we gotta do a deep biopsy
Right,
and multiple biopsies to be sure
Yeah.
that there's no cancer remaining in the bladder. Now, that's the ideal situation where you wish you had a blood test or a more sensitive urine test to tell you if there's any cancer anywhere. But you can do that, and we have patients who've gone for, that's been it for them. They haven't needed any other therapy other than watchful waiting.
Dr. Linehan,
I mean, I've definitely seen those patients in my practice, and how things have gotten started is that, you were supposed to get the chemotherapy and then we take your bladder out, and that was the standard of care.
Right.
And then you'd have patients where they got the chemotherapy and then you took their bladder out and there was nothing left.
Yeah.
yeah.
And
And then
so,
the good news is,
Yeah.
the bad news is I took your bladder
Bladder
out.
out.
The good news is there's no cancer.
right, so then if there's patients that, if I look in their bladder and the tumors are small, and I think I can get it all by carving it out, through the scope, those might be good candidates for just having chemotherapy and then following them along and see if it worked. I've also seen the same results with the immunotherapy. They just had immunotherapy. That's all they had. And we've watched them very closely to see if the tumors come back. So I think there's more and more options that are going to be coming available. We just have to study them.
And when somebody does that, is the surveillance, is the watching after the chemotherapy and any other resection, is that more often than you would do otherwise? Is it like more than every 3 months, or?
Not in general, it's probably
Okay.
every 3 months, but it's longer in years, I think.
Right.
I would watch them
Okay.
every
A
3
bit more
months.
intensive.
Yeah.
So, yeah,
You're still worried about it.
Okay.
I may interject. So, again, this is all what we are talking is still being under investigation. So the early results which were presented this year showed 1 out of 3 patients will recur with advanced disease if we don't remove the bladder.
But you said 1 out of 3.
1 out of 3, so close to 30% patients will recur, and that's risky versus doing something definitive, either a radiation or surgery after chemo. I'm the one who give chemotherapy, and I'm not kind of undermining its value by saying that, but chemotherapy can potentially leave cancer behind, and it may be very difficult for urologists to find that cancer because they can't just scoop out all your bladder to confirm that it's gone. On this trial itself, because I have to review all charts, I'm seeing patients undergoing radiation, chemotherapy. The surgeon goes in, they don't see anything. And they call and ask, do we really need to biopsy? And I say, yes. And so they do a deep biopsy and they find cancer, deeper layers of the bladder still persisting. So not removing the bladder is still in early investigation where we are figuring out which is the right candidate to do that. But I would not use this as a general advice at this time because the data shows that it is risky to leave the bladder in post chemotherapy. Maybe we need to figure out a better combination. Maybe the newer delivery systems and the immunotherapy combination, which are showing remarkable response in advanced disease, may take us to a point where we will consistently see that patients are having no cancer in the bladder. So John, the trial he's on right now is looking at that combination in before we remove the bladder. So the trial mandate us to remove the bladder because we are going to find out if once we give them that chemotherapy, how many of them truly has no cancer. If nearly 7, 8, or 10, or 9 out of them are having no cancer, then it may make sense. Why would we need to remove that? But I think it is still early in, it has to be done on a clinical trial, not as in a general advice. Now, besides that, what we truly do, and like Dr. Lamm and you, I also have patients who have just put their foot down. No, I'm not removing my bladder. So there is actually now a test, which is a blood marker approved by Medicare, which can take your biopsy specimen, your tumor, and then look for and do the DNA testing on your tumor, and then try to match that into your blood to see if you have any of those similar mutations in the blood circulating. And that test can pick up very, very small amount of cancer if it still exists in your body somewhere. It was approved last year, so we're still learning how to use that or interpret that results in context of clinical situation. But I have done a gentleman from Flagstaff who was like, "Doc, I don't want surgery no matter what. I accept all the risk." We gave him chemotherapy, we did the biopsies, they were all negative, and he decided not to go for it, but I'm doing that test. But again, it's very risky and it should be only be done under a clinical trial context, not as a general advisement.
I want to give enough time for questions, but I also want to have one more area, which is not as common, but I also want to recognize it, upper tract disease. Are there new treatments or new trials looking at upper tract disease?
I mean,
Or-
so,
Anybody?
so one of the newest treatments, so this is where I was actually explaining this to my mom. So the cells that line the bladder and the kidney are the same type of cells. So you can get bladder cancer or urothelial carcinoma up in your kidney. That's upper tract disease. And so you can have low grade and high grade, just like in bladder cancer. And there is a new therapy for low grade upper tract. And it's basically a hydrogel that's liquid when it's cold. And when you shoot the gel, either through the back, through the kidney, or up through the bladder into the kidney, as soon as it gets to body temperature, it turns into a gel and it stays wherever you put it. Because if you could imagine, if you put a liquid up into the kidney, it would just trickle out and you'd pee it just out. So it would never stay in there long enough to actually interact with the cancer and treat the cancer. That's called Jelmyto, and that's currently approved for low-grade cancers right now. And there will be more intra-kidney therapies and cavitary therapies that you can use. You can also use BCG in some of these cases, and you have to instill it through a tiny tube called a nephrostomy tube into the kidney as well. And there are more, I think a lot of the immunotherapies are the same that work, for bladder cancer, can also be applied to upper tract as well.
So if somebody's had high-grade upper tract and had their kidney removed, and so they're being watched, is there anything you can do proactively? Because we know that oftentimes upper tract, the tumors can then show up later in the bladder. Is there anything you can do, or is there any research being done looking at sort of being more proactive in that regard?
Oh, my. That's a very important field. It's very hard to do studies to determine that something is effective,
Yeah, because you don't
40
really have a
years.
target, you're shooting.
Yeah, 40 years ago, we looked at high-dose vitamins, Oncovite, and we found a huge advantage. And then we did a larger study, and it didn't turn out to be any better than the 3-week maintenance BCG. Well, you can't protect something if it's not there to protect. But your vegetarian, plant-based diet, your exercise, staying out of quitting smoking, obviously, are some things that may help. When we remove bladders for muscle invasive disease, we find that 17% of the time, the distal ureters that also come out with that operation, 17% of the time, there will be carcinoma in situ there. So it is always a concern that, especially with medications that are just topically effective, like intravesical therapy, that the medicine is not getting to where it needs to be. So you do see delayed, late failures in the upper tracts, and it's something that we have to be aware of and continue to watch out for.
Okay. Well, I just think, in all my patients that if they've had high grade upper tract urothelial carcinoma, they still need cystoscopies. Urine tests looking for upper tract disease we're still figuring that out, but there's better ones coming out. And then of course, imaging, following them closely with, scans as well.
Well, so we've got 30 minutes left. So I'd love to open it up for questions.
I have the
and
first
we-
question and then I'll come around
Okay.
with the microphone. So
Stephanie
give
and-
us a second. The first question, what are the clinical outcomes that you are seeing with a reduced dose of BCG due to the shortage? Dr. Lamm.
Well, the AUA has a guideline, and it says that just give full strength BCG for 1 year. And the study that's kind of based on, one of the studies that's kind of based on is the Odin study, where they looked at 1 year and 1/3 dose, double randomized to 3 years and full dose, mixing that up so it's balanced. And for the intermediate risk patients, they said that, well, 1 year full dose is enough. And actually, if you look at the curves, the group that got 1/3 dose for 3 years did better, not statistically significant, but their line was above the group that got a full dose for 1 year. And it's less BCG. It's enough BCG to give several other people there another induction. So it's, if you can extend it out for the 3 years, it is not, it is probably, and we don't, there was almost 1,000 patients in that study, but that would be my preference if I was getting.
But I think maybe Stephanie's question was in context to 1/3 dose of BCG. Because of the shortage, folks are using 1/3 of the BCG, what they would put in the bladder if the BCG shortage was not, right, Stephanie? Is that the question, right?
Yes, absolutely, absolutely. Absolutely. Now,
Doing it over years, like, as
Yeah.
I said, 1/3
Yeah.
dose over
And-
3
and-
years.
Okay, got it.
Next question.
and wait, but can I say one other thing? It is clear with intravesical chemotherapy that what counts is not the dose of chemotherapy, not how much you put in, but the concentration. It gets into the bladder down a concentration gradient. So the more highly concentrated is, the more effective the penetration is. And I didn't get a chance to talk about that yet, but we were involved in a study looking at nanoparticle docetaxel, which in animal models goes all the way through to the muscle layer of the bladder, and it's very encouraging results with that. So it isn't, I don't like to confuse chemotherapy with immunotherapy, but there's no reason, there's nothing magic about 50 cc's. There's no, people sometimes will draw a picture of bladder and they'll, it's half full. Well, you see half and there's air in the rest. There is a bubble that goes in, which is the air that was in the catheter. So you need to get up off the table, really, is all you have to do to displace that bubble. But you can put a third dose in a third volume and have the same concentration. And hasn't been done in the studies. That's what I've always done. Also, you can warm the solution with chemo, again, and chemotherapy analogy. It's a chemical reaction. What speeds chemical reaction? That's Chem 1, increased temperature. So just warm it. And we wrote a paper and they say it's 43 to 44 degrees centigrade. Well, that's too much. We did that for a while. That's too much trouble. It's baby bottle warm. And you all know what baby bottle warm to the inner arm is. And, you have a heating pad, you put your water or saline in whichever you're, depending whether you're giving chemotherapy or BCG. And it's right there, and it doesn't take any longer, it doesn't cost any more, and it hasn't been proven, but logic says it should be a whole heck of a lot better.
Dr.
And think
Lamm,
of all of
how many
BCG we could
induction
say.
courses can you give?
Pardon?
How many induction courses can you give of BCG?
The famous Catalona study was if you give 3, it's too high a risk of disease progression. But it depends on the interval between courses. And I much prefer, rather than if somebody's been off for a while, I much prefer to give 3 and then in 3 months, 3 more, rather than continuous 6. Some people have such a mild reaction that they may well need 6. So if they had no symptoms with the first 3, you could carry on to the 4th, 5th, and 6th treatment. And we can't go by, so don't worry if you haven't had symptoms, because some people have never had symptoms and never had a tumor back.
Next question.
Okay, thank you. 2 quick things. You talk about the CX bladder treatment in lieu of a cystoscopy, and also, is there is CAR T cell therapy, in other words, T cell transfer therapy, is that on the horizon for bladder cancer?
You want to talk?
Okay,
She's a CX.
Yeah, so for the CX bladder, there's been good evidence showing that you can use it to hold off on cystoscopy in screening patients. I think the data is coming out of whether we can hold off on doing it in patients we know have bladder cancer, where you're using it to monitor them. Again, I'm making that decision very individually based on the type of cancer the patient had, how often they're recurring. So whether it's high grade, low grade, and how often they're recurring. But I think that's the hope as we gather the data on these urine tests, that we'll be able to say, okay, you could push cystoscopy off to from 3 months to 6 months if the CX bladder test is negative. And again, I'm doing that in patients that I'm screening in. So the patients come in with microscopic hematuria, and if the CX bladder test is negative, then I might hold off on doing cystoscopy and just follow them for a bit. But patients that we know have bladder cancer, that's still a little different.
Did you also ask about blue light?
No,
Was your
CAR
question-
Oh, no, he asked about teeth out.
CAR T cell.
CAR T cell.
Yeah.
So actually, CAR T cell,
Yeah,
that's
CAR
a
T cell.
it's a very good question, because a lot of patients ask for it because of the media attention on CAR T. So I'm just going to give you a very simplistic explanation of why CAR T cell is complicated option for bladder. Is any immunotherapy, which is targeted immunotherapy, where you're training an immune cell to go after a cancer cell, or you're developing a targeted immunotherapy, then you have to have that defined target on the cancer cell, which is not seen on other cells. Otherwise, your immune cell is going to go and hurt both the cancer cell and the normal cells. Now, we spoke about that antibody drug conjugate, which I was so fascinated about. It goes after a target which is there in 85% of the bladder cancer cells. But unfortunately, that target is also expressed on the skin. And so as the chemotherapy goes into the bladder, it also goes into your skin. So I have folks who will get bad skin reactions. In the beginning, when we were just new with this and we didn't know what was happening, and we had some patients who had really, really bad reactions and they died from the skin reactions too. So it's risky. But now we know how to deal with all this. So we don't see that kind of bad outcome now. But for any kind of immune therapy, you have to have a defined target, which is expressed only on the cancer cells. So for lymphomas and leukemias, which are characterized by a certain protein on their surface. So different leukemias have different targets, which are very specific for that type of leukemic cell. It is easy to make CAR T therapy or lymphomas. But for bladder or any solid tumor per se, it is difficult to create such treatment options. So but now we have just started to go into the solid tumor field by first taking prostate cancer, because there are certain things which are peculiar about prostate cancer that we may have a particular target for prostate cancer. And Mayo Clinic is going to open those trials shortly. But I don't have anything coming up in bladder yet because we haven't figured out the right target in the bladder. But otherwise, the other options, which are the field is moving in a way that I think we will be able to have a good handle even in advance of these patients with the other new options which we have.
Next question.
From the back.
Oh.
I'm Peggy, and a test was mentioned to see if the patient will respond to the BCG treatment. What is the test and where is it available?
So the test is the Oncuria test. It's a test.
Oncuria?
Oncuria, yeah,
Oncuria.
test. It should be widespread available. I mean, it's FDA approved. They should be able to get it into institutions. We do have it. It actually originated out of Cedars and in Los Angeles. So we have it, but that test does look at characteristics of the urine that will say this patient has a higher likelihood to respond to BCG. Now, should you not use BCG based on just that? I'm not saying that for certain, but it might give you a better idea of how this patient might do. Or maybe you're saying, okay, we're going to try BCG, and if it doesn't work, we're going to move on to something else right away instead of doing a second, course of BCG. So, I mean, we have a lot of information that's coming down the pipeline, and how we use that is always going to be very individual right now to each patient.
We have some questions, Stephanie, we also have questions up here, so, okay.
All right.
Go ahead.
Hello, my name's Alan. And my question is that if a patient becomes septic to BCG after going into maintenance, is there new procedures that they could get back on BCG because it was effective? But, because I'm being told by my doctors that they won't do BCG anymore. Okay.
Yes. Well, a bit of good news first. The patients who have a very serious reaction to BCG often don't do well without further BCG. That's a very strong immune reaction that can last a long time. We have had patients who were very BCG intolerant. One woman whose father died of bladder cancer had very long-lasting, severe irritative symptoms that eventually responded to antibiotic therapy. And because of her high risk, we put her on heat inactivated BCG. Actually, my first animal study in bladder cancer in 1973 was with a cell wall preparation of BCG. It wasn't the live organism. There's advantages to the live organism, one of which is it persists, can persist for a long time, so you get a long stimulation of the immune system. But once you have been exposed, a second exposure using heat killed or inactivated, or there are cell wall preparations, not, of course, not commercially available, but there are preparations that can be used. But simply autoclaving the BCG and giving a reduced dose can be done, and it seems to be quite effective. We don't have good comparison studies to say that.
Okay, can you hear me? Yeah. Okay, so I had a question. If you have T1 high-grade CIS and you've got 6 weeks of BCG, a half dosage, and you didn't respond, is that long enough to know if you could respond or not?
It depends on when you say didn't respond. It will often take more than the 6 weeks after you finish the BCG for the immune response to completely get rid of the carcinoma in situ. If it's increasing, it shouldn't be increasing, it should be decreasing. So if you go from, multiple sites of carcinoma in situ, I assume that the T1 disease was resected, or if the T1 recurs, then it's getting a little too risky perhaps to continue. But sometimes it takes 6 months for the BCG to completely respond, and we give 3 installations, not a second 6, but 3 at 3 months, and then it will typically respond by 6 months. I have had patients go as long as 9 months, but that's kind of pushing it.
Okay, but if it's reoccurred with multiple tumors, then it probably
Yeah,
go
it's time to go to something else.
to go to chemotherapy. Okay, thank you.
Hi, I know of an integrative doctor that does immune therapy, like ozone therapy, high dose IV, vitamin C and other things. What is your opinion of those types of therapies?
Is in context with advanced disease or localized disease? In context to advanced bladder cancer or localized bladder cancer?
To cancer,
Just in cancer?
yeah.
So, it's a tricky question to answer for us because there is no strong data behind all this. So whatever trials have been done in cancer even by NCH, there was a large trial, select trial in prostate cancer looking at selenium and vitamin E, and and it showed poor outcomes in patients who got supplementation. So I generally tell my patients that you have to think about it in this way, because there is lack of data. It is quite possible that taking high dose supplements may actually be helping your cancer cells also, because these are your own cells. They are not aliens or foreigners jumping inside, or they're not viruses or bacteria. These are cells which have become rogue, and they have similar mechanisms inside them as your normal cells. So if you think your high dose vitamin C is going to help your immune system, it's also going to help the cancer cell in some way or form. And so my suggestion usually to patients when they ask me about all these therapies is to avoid this because there is lack of data. Now, in context with radiation therapy, our radiation oncologists, they always tell patients not to take supplements because there is higher oxidative stress in the tissue when they are radiating, and that can lead to more adverse effects. So certainly with radiation, we tell not to take it. But in conjunction with other therapies, I usually tell patients to avoid it, and that's the reason behind it. But there are clinics here in Scottsdale, unfortunately, who claim to offer low dose insulin, vitamin C and other supplements, infusions, ozone therapy to cure cancer. But again, the data, there's no true data, randomized data to support all that.
Oh, yeah, first of all, I want to thank you all for being here to share your expertise with us. It's very much appreciated. I have a question. I think you kind of circled around this a little bit. For patients who've had radical cystectomy, one of the things that we all worry about is upper tract recurrence. My understanding is the current protocols for screening are periodic CT urography, which can miss very small tumors or CIS, and urine cytology, which kind of lacks the sensitivity that I think most of us would like. There are other tests like CX bladder, but I believe you have to have your native bladder in place for that. So how do you screen for upper tract in post-RC patients these days?
I mean, the best way is gonna be, the best and safest way at this point is gonna be imaging. And I still look into the neobladder to make sure that there's no cancer recurrence in the neobladder, because that would also tip me off. And, or, in the ileoconduit too. But I mean.
You scope them on a routine basis?
Yeah, in the very beginning, yeah, I do. But I mean, the imaging is gonna be the best test for this, because at some point it will be large enough that you will see it in the ureter. And if you're suspicious of something else, you know, in the bladder, then you may want to investigate more in the conduit or in the pouch, whatever diversion the patient might have. I also think the test that he was talking about, which was the blood test that matches your cancer, I think that's another, that will become another good, helpful watch test. And if that's positive, you're like, okay, well, where is it then? I got to start looking.
But would that require having a fresh sample of the tumor? I mean, something from years ago, would that still, could you still match it?
So good question. So, just to explain the audience again, what we are talking about here is a test where we take your tumor sample, we check your DNA, and then we look for those changes in the DNA in your blood, because then you're not looking, so it's essentially looking for a needle in a haystack, but because you now have a magnet which can pick up the metal, so then it is easy to find that needle in the haystack versus you just scrambling the haystack. So, so the question is, if the bladder was removed many years ago, will that test hold good now if we try to do this? So this is an unanswered question, because that test was just approved last year. And as I said, we are also learning how to use that in context. At this point, the Medicare has approved it in patients who had bladder removed. And when they remove the bladder, there was still a lot of cancer. So there is a risk that the cancer is floating already in your blood. And so those patients, we can do that test to look for if there's any cancer left, which is not being seen on the imaging, but not in context with somebody who had cystectomy many years ago, because it is possible that now the cancer you are going to show up in your upper tract may be a new cancer and may not harbor the same mutation as your previous cancer. So, but again, the field is moving very fast. With AI coming in, we are at Mayo Clinic, we are doing using AI platforms to read your scans. So we are feeding in data from like 20,000 scans with various changes in patients who then had their bladder removed or kidney removed and they found cancer. So then AI is going to help radiologists localize that, oh, this is something which is suspicious. So then the chance of us missing a small lesion will go down. Similarly, I think in bladder space also, Mayo is looking at an AI platform where the urologist will put a camera inside the bladder. The AI will read the images in real time and put a circle around a spot where AI thinks there is cancer, even if it is not seen by the urologist. Like the white light, you saw there was no lesion there from the naked eye, but there are still some changes there which the AI can pick up, and then the AI will circle that area. So then the surgeon can go in and take a biopsy, even if nothing is seen there. And then if the biopsy is positive, then we may find cancer. So again, the field is moving very fast. Things are going to change in the next 2 years at a very fast speed.
Thank you.
I had a question about, for those people who, you know, it's not clear that they are a candidate for cystectomy because they're not stage 2. I've seen some studies saying that perhaps some people at maybe a stage 1 could get a benefit from considering a radical cystectomy earlier on. What studies are being done in that area? And, you know, when exactly should that be at least discussed?
So could you repeat that question?
Yes.
So
Thank
were you asking about patients who don't have high grade?
so I had a high-grade cancer, but it, it was like a stage 0. When should a radical cystectomy be considered? I think I've seen some studies where maybe, it became clear based on some results that, there was some muscle invasion that was not detected.
So high-grade stage cancer, would you ever consider cystectomy earlier?
Yeah, I mean, there are cases where I would consider cystectomy in those patients, but that's pretty rare with all the intravesical therapies that we have now. I have patients where they have so much pain from their cancers, from the resection of their cancers. They're having high rates of recurrence, and recurrence are multiple tumors all around the bladder. And we're having to do more and more cystoscopy, more and more procedures to try to keep up. We're doing intravesical therapy, but they're still recurring. Those are the people that I'm really going to sit down and say, okay, look, we've done, 2 rounds of BCG and 3 clinical trials of, different drugs intravesical, and you're still recurring. Like, do we have to have a talk about that? But I think that situation is really rare. And I don't know any of, my other urologic oncologists that would, push patients into that unless it was an extreme situation.
A related question to that, because we've had this question before. So if you're diagnosed with, say, a TA high grade and you've resected it, 9 watch, what's the chances of recurrence of it being like T1 or T2? Because it started as high grade.
So the chance of becoming T1, or the chance of recurring period, remember, is about 65%, okay, in general. The chance of it becoming T1 is about 30, and the chance of it becoming T2 is about maybe 10.
Okay.
I mean, in patients that don't have any intravesical treatment. Right.
Yeah.
Right.
But again, there will be patients who are outliers. And, I'm pointing out to you, Dan, again, but, Dan was T1. And then when I saw him with T1, we were thinking about giving immunotherapy, but then he ended up having stage 4 disease, now in remission. But there are patients who we may miss. I think that's what Maggie, your concern is, that you may miss in an early disease patient. Are we missing somebody who has advanced disease? Those patients are outliers, but they happen in our practice. Sometimes we are fortunate or lucky that we end up doing some extra testing. We may pick up the disease, but most of the patients, we can follow them. And the idea here is to preserve the native bladder function as long as possible, and then remove it when we think the cancer has become too risky, and go after it.
It's why we call it the art of medicine.
I think in the 23 years I've been doing this, I mean, the number one lesson I've learned is that medicine is an art, not a science. Yeah.
Question. Do any of you know or aware of any?
Yeah.
It's on, just hold.
Yeah, there you go.
There we go, okay.
Yeah.
Would any of you know or be? Okay.
She's got you.
Thank you.
She's got you covered.
All right. Are you all aware of any FDA approved treatments or procedures that have been successful for bladder cancer?
Yeah, there are a lot of procedures which are not FDA approved, and FDA is reviewing that data because we have done clinical trials. So you see the list of the clinical trials. Many of them are either ongoing, they are not approved, but they are in clinical trials, or if the clinical trials have completed and the FDA is reviewing the data to see if data merits approval of that drug. So those medicines come under the purview of unapproved strategies, or you can say drugs. Now, Gemdosi is in clinical trial right now, but we can still give it to our patients. We are trying to, because there is no clinical trial data showing in a randomized way that Gemdosi is as good as BCG or maybe even better. So the confirmatory trial is ongoing, but FDA allow us to give Gemdosi to our patients because of the lack of BCG, if we want to give it in our clinics. Similarly, immunotherapy in combination with chemotherapy is not approved. But, we can make cases, because there is indirect evidence that they may be beneficial, that we are able to get the insurance or Medicare to pay, or sometimes even get the pharma company to just give it to us for free to our patients, where we think that's where the art comes in, where we think that this patient may truly benefit with this combination. We may ask for an off-label drug use. We do that all the time in our practice.
And it's my understanding gemcitabine cisplatin was never approved for bladder cancer, and it was the standard of care. for
It was
metastatic disease.
metastatic disease, yeah, yeah.
There are a lot of disapproved drugs that are also quite effective.
Yeah.
Yeah.
I was going to give the example of one of my patients who had low-grade tumors, not huge, multiple, but frequent low-grade tumors. And we tried everything. I finally, I'm going to give you some KLH, keyhole limpet hemocyanin, which is an immunotherapy from the Pacific Sea slug that's approved in Argentina and Austria and other places, but failed in the United States because while a previous study comparing it with mitomycin in Germany found it to be better, they approved the mitomycin treatment subsequently, and it turned out it was not as good as mitomycin, which of course is a good drug. So it's disapproved, but it's available. So we gave it to her. And after having tumors multiple times a year for years and years and years, decades, she'd never had a tumor yet. And so we miss her. We see her once a year.
Carlos, I think the last question.
Yes, I was just wondering if anyone on the panel can comment on FDA's recent approval of that Strilodrin.
So, I'm gonna, you answer that, yeah.
You can go in, you can go in.
No, that's your space. Non-muscle invasive bladder cancer.
So this is another intravesical therapy that has been approved. Like we were talking about earlier, there has been some production issues with it. So it's not become as mainstream, but it is approved as another intravesical therapy that we can use. Is
Yeah.
it a replacement for BCG? I don't think it's there yet, but it's definitely along the lines of different strategies that we can use for patients with, high-grade and CIS disease, in that setting.
I think it's coming this fall. That's the.
Yeah, that's what.
I
yeah,
hear.
have
This
the,
fall. So there's in the
Do you want to add
production.
anything to
No,
that?
I was just the same thing, we said that, again, FDA looks at not just the drug activity, but also, and I'm learning all this because I'm part of being all these clinical trials, is that they even go and inspect the facilities where these drugs are manufactured. And if those facilities have all the benchmark standards met, I don't know, don't quote me for this, but they found in one of the swabs some fungus in that factory. So then they had to shut that factory down, and they'd have to rebuild all that. So that's why the delay is happening. But that's what I heard. But again, I don't know, did you hear the same thing?
Well, no, but that's the same thing that got cannot BCG
Not
in
BCG
Toronto.
yet, or, yeah.
They found some fungus somewhere, and
Yeah.
so
They
they
shut the manufacturing.
they shut it down, and they built another one, and then they had 100-year flood, and
But to Dr. Lamb's point, I think having the more drugs that we have that we can use, you never know what's going to work in a patient. And I think eventually we'll get to figuring what's going to work out best intravesical in patients, but the more options we have available, it's better for patients, period.
Well, I want to thank you all again so much for your time and expertise and sharing your Saturday with us. So thank you very much.
This is wonderful. Keep up the good research. And if we could put on the last slide deck. Yeah, this is wonderful. Thank you guys so much. This has really been enlightening. I love to see what gets you excited. And, the things you've been able to talk about now, we didn't have even at the very first patient summit that we did 8 years ago.
Yeah.
So this is really an exciting time, never a good time to have bladder cancer. But comparing to 8 years ago, it's a much better time
I'm
if you
just
have
trying
to.
to-
But
Oh, picture?
Yeah.
Picture. Come back. Thank you so much,
excellent,
everybody.
excellent. Okay. Super. Now where's can I have the clicker?
Dan's got the clicker.
Jen's got the clicker. Okay. Thank you so much for everything. So wrapping it up, we've talked about nutrition and taste. We gave you some samples. We gave you some recipes. Lymphedema was a hot topic, yeah? Doesn't happen to everybody, but now you know about it. And you know more about rehabilitation before treatment, during treatment, after treatment, all of those things. I hope you have a better sense of addressing anxiety and fear. I will be sending out an evaluation, and it's going to have some follow-up links in it because so many things that we've done and talked about, we also have more resources. So it'll be a long email, but it'll have a lot of good information in it. We talked about the strategies for dealing with sexuality issues. I think that was a great program this morning. I hope you got a lot out of thriving and surviving, and the new research patient advocate groups that we are trying to keep going. So I will add all that in an evaluation email. So I want to find out, just raise your hand. Are you better informed than before you got here? Yay. Okay. Are you better connected to other people that know? Good. How many of you got your sheets all filled out? I see a lot of blank pages on the tables. Okay, so are you still confused if you're a patient, a survivor, a family friend of one, a carer, a caregiver? All of the above. And it's really hard to just, pick the right term to describe. I tried the best I can to try to be encompassing, but I do want to say that you all now have a bladder cancer PhD. You've all been touched in some way by the 6th most common cancer in America that nobody talks about. What's a bladder cancer PhD? It's a personal history with the disease. So you are all better educated. So you can say, I have a bladder cancer PhD. Whether you are a loved one, family member, or the person who was diagnosed who's now a long-term survivor or about to go through treatment, you got this, okay? Thank you again to the sponsors that made this possible and free of charge. This is what we really appreciate, is being able to do what we love to do, which is connect with you. And remember, I had you guys take out your phones before. I promise, I will hound you until you get this done. But I am giving you a first crack at the survey right now. And I'm letting you know, if you get it done before Friday, you will be eligible to win this very nice, it is very nice and stylish beacon jacket that you can rock on any walk anywhere in the country. So make sure you get it done. The email will come tomorrow. I have to finish it, and it will come tomorrow. Thank you. Safe travels to wherever it is you have to go.